Palliative and hospice care and healthy aging. What to do at the end of life. The objectives for this lesson are to appraise the benefits of palliative care and hospice and comprehend the value of advanced care planning. Here's some guiding questions for care of older adults from the American Geriatric Society. First, what is the prognosis and how does it impact longevity, functional status, and quality of life? Second, what is the complexity and feasibility of clinical treatment? And third, what interventions optimize benefits, minimize harm, and enhance quality of life? These three questions should guide all care and treatment of those who are aging so that they can be at their most optimal health status when they're aging in America. So end of life is when curative care is no longer effective and the person and their family are ready. Palliative care or hospice care may be provided. This type of care focuses on the person's quality of life rather than curing their condition. Each procedure, treatment, medication, lab draw is examined within the lens of the person's quality of life. There are three different types of care. Curative care focuses on a cure to an illness and the prolonging of life, whereas palliative care focuses on comfort and quality of life that may be provided with other treatments. And hospice care focuses on comfort and quality of life when a cure is not possible with specialized care and services. The majority of an adult's life is in the curative care category, but once they get to a certain point, palliative or hospice care is necessary, and the most important thing is their quality of life. Here's a picture of what the usual trajectory looks like when someone is going from disease-directed therapies to palliative care. So what is palliative care? It's specialized care for people with serious illness. It focuses on providing older adults with relief from symptoms, pain, and stress of a serious illness who are not ready or eligible for hospice. The goal is relief from distressing symptoms, the easing of pain, and or enhancing the quality of life. Palliative care team members include the person's personal physician, a medical director, usually a hospice physician, nurses, social workers, clergy or other counselors, and trained volunteers. Here's some myths and facts regarding palliative care. The myth is that palliative care is intended for individuals who are dying, whereas the fact is that palliative care is about living well. It operates to achieve the best possible quality of life. The services provided are designed to ensure the person is comfortable and their pain and symptoms are managed. Here's another myth. Palliative is only for seniors and people with cancer. Here's the fact. Palliative care is available for people of all ages who are living with serious and life-threatening or terminal diseases. Here's another myth. Palliative care means a person's doctor has given up treating their illness or condition. Here's the fact. Palliative refers to the change in treatment from a curative to a comfort regimen. Although there may not be a cure for a person's condition, it can still be managed to keep the individual as comfortable as possible. Here's another myth. Palliative care is only provided in a hospital setting. But here's the fact. Palliative care can be provided in whatever location is best suited for the person and their family. Care can be given in an outpatient or inpatient setting, and even at home. Here's another myth. Palliative care relies heavily on pain medication. Here's the fact. Pain management is tailored to each individual. Taking medication plays a major role in managing pain and ensuring comfort for people in palliative care. However, non-medicated approaches to pain management are important too. And here's the last myth. Families are not included in the palliative care process. Here's the fact. Families play a major role in the decisions regarding the loved one. Healthcare professionals provide guidance and help foster healthy communication with the family about their wishes, as well as those of the individual. So as you can see, there are a lot of myths in regard to palliative care. Palliative care drives a positive experience. It improves quality of life and symptom burden. It's known to reduce symptom distress by 66%, with improvements lasting months after initial consultation. There's also a very high satisfaction and positive patient experience rate at 93% when palliative care is received. It also improves cost effectiveness. It reduces avoidable spending and use of healthcare services in all types of settings. For example, it's known to reduce readmissions by 48% and the cost of care 28%. In the outpatient setting, it's reduced care 50% and reduced 35% of emergency department visits. It's also reduced skilled nursing facility admission by 43%. And if home-based palliative care is received, the overall cost of the services and care has been reduced by 36%. So what about hospice care? Here's the fact. 25% of deaths occur at home, but more than 80% of Americans would prefer to die at home. Hospice care provides support and care for those in the last phase of life-limiting illness. It recognizes dying as a part of the normal process of living and affirms life and neither hastens nor postpones death. It focuses on quality of life for individuals and their family caregivers. Core aspects of hospice include that it's person and family focused, it's interdisciplinary team care, and a range of services are provided. Case management, pharmaceuticals, equipment, supplies, volunteers, and grief support. It also includes hospice residential care if needed in a facility, inpatient hospital hospice care, complementary therapies, specialized teams, caregiver training, and community bereavement services. Hospice team members include the person's personal physician, a hospice physician, nurses, aides, social workers, clergy or counselors, speech, physical, and occupational therapists, and trained volunteers. Work of the hospice team includes developing a plan of care, managing pain and symptoms, attending to the emotional, psychosocial, and spiritual aspect of dying and caregiving. It teaches the family how to provide care and advocates for the person and their family, and provides bereavement care and counseling at the right point in time. Hospice can be provided at a person's home, in a nursing facility, assisted living facility, hospital, in a hospice residence, or a correctional setting or homeless shelter, wherever the person is located. Who pays for hospice? It could be Medicare, Medicaid, insurance, HMOs, or it could be private pay or a combination of these. Admission to hospice has certain criteria. To qualify, there are general requirements such as having a life-limiting illness where the prognosis is 6 months or less if the disease takes its normal course. They live in a service area and consent to accept services and forego other medical interventions for the treatment for the terminal disease. Here are a couple resources that provide very good information about hospice and palliative care. They provide tools to help with advanced care planning and show many of the benefits of hospice care through videos and stories. In summary, part of healthy aging is addressing end-of-life care that focuses on quality of life. A key part of hospice and palliative care is doing advanced care planning when you're able, as an adult, to determine what you would like to have at the end of life. Because even at the end of life, healthy aging with the best possible quality of life should be attained. Thank you.